A very warm good evening to everyone who have joined us today for celebrating World ORS Day 2022. As the speaker rightly said, the game changer in the significant reduction number of deaths associated with diarrhea. We have our eminent speaker, Dr. Bharat Parmar, MD Pediatrics, DHA, FAIMS, Professor and Head of Pediatrics Department, Zydus Medical College and Hospital, Dahod, who have joined us to give us an insight about ORS from the history to the application level in the hospitals as well. Thank you, Doctor, for joining us today in celebrating ORS Day. Over to you, Doctor.
Okay. First of all, I am very thankful to you for giving opportunity to highlight these subjects. There is ORS, oral rehydration solution. It is one of the advanced therapeutic in the 20th century for the reduction of this mortality due to diarrheal disease, and also important for the prevention and reduce the morbidity due to diarrheal disease. So one selective strategy of the WHO, that is GOBIF, G for growth monitoring, O for oral rehydration solution, B for breastfeeding, I for immunization, F for family planning, another F for food supplement, and another F, there is a female education. It is recommended by UNICEF, GOBIF triple F. During the 1980, UNICEF launched one program. There is a CSS. There is a Child Survival Development Revolution, concentrating its efforts for a four potential method of saving children's life. One is growth monitoring, second is breastfeeding, third is immunization, and fourth important, there is ORS, is the best way to combating the dehydration caused by diarrhea. The British medical journal, The Lancet, has described ORS as a potentially most important medical advance of this century. The two pillars of management of acute gastroenteritis are an immediate attempt at a oral rehydration and rapid introduction of the regular feeding following initial fluid rehydration. Oral rehydration therapy, described as a potentially the most important medical advance in 20th century by Lancet, and resulted in number of the deaths associated with diarrhea. Despite being one of the most important scientific discovery, it has helped millions, and the recognition given to the researchers like Richard Cash, Michael Pierce, Dilip and David, and others who work to prove the benefit of ORS has been disappointing. The stool output in an adult, it is less than 250 ml per day. This amount varies by the age in children. During the diarrheal disease, the intestinal output increased greatly and overwhelming resorptive capacity of the intestinal lumen. And multiple studies done among the cholera patient demonstrated an intact sodium coupled solute co-transport mechanism. There is a sodium glucose co-transport along efficient salt and water reabsorption. So mechanism of ORS, because of the sodium glucose co-transport system in the jejunum, which contain SGLT1 transporter protein, and sodium transport and the glucose transport are coupled in a small intestine so that glucose accelerate absorption of solute and the waters. If the sodium and the glucose consume in 2:1 ratio, the SGLT1 channel actively transport both from the gut across the epithelial wall into the cell. An osmotic imbalance is created, wherein in the osmolarity of the cell increases due to the influx of sodium and the glucose molecule, Hence, to maintain osmolarity of the water is absorbed from the gut and into the body. Both the fluid and electrolyte are instantly replenished due to these ORS. And the previously used higher osmolarity ORS, there is a conventional ORS during 1975 and 2002 has been replaced by low osmolarity ORS by the WHO UNICEF in 2002. So what is the principle of ORS? Principle of ORS therapy in diarrhea is based on the following facts. Large amount of the fluid are lost in the diarrhea, which needs to be replenished with the fluid. And substantial amount of the sodium and other electrolyte are lost in diarrhea. As the sodium is a principal determinant of extracellular fluid osmolarity, its presence is must in ORS. Water absorption in a gut is a largely passive, dependent on the active sodium absorption. Absorption of the glucose and amino acid is a carrier dependent and remain largely intact in the most of the case of diarrhea. As a carrier mechanism for sodium absorption are largely interlinked with glucose, amino acid absorption, and ORS facilitate the recovery in case of diarrhea. And excess intake of the glucose may cause osmotic diarrhea. So important thing, two things is important in case of ORS. One is glucose and second is sodium. If it is sodium is less, it decreases the volume of this diarrhea volume and also decrease the duration of 24 to 48 hours and also the severity of dehydration due to this diarrhea. In excess intake of the glucose, it causes osmotic diarrhea. 1:1 molar ratio of glucose and sodium considered ORS is the most appropriate to maximize sodium resorption with a minimal osmotic load. As potassium and bicarbonate losses are common in GIT fluid, ORS should contain minimum required concentration of these electrolytes, that is potassium and bicarbonate. Glucose, when given orally, it enhances the intestinal absorption of the salt and water. Thus, it can correct electrolytes and water deficit. Oral rehydration therapy is a preferred mode of fluid replacement in diarrhea for first, prevention of the dehydration, and second, correction of the mild to moderate dehydration. It may be safely used in all cases of diarrhea except those with a paralytic ileus. Children with vomiting may be given oral fluid after antiemetic therapy after 10 to 15 minutes. Oral rehydration solution is one of the most important medical advances in revolutionized treatment in acute diarrhea in children, and it reduces about mortality more than 80% due to the diarrhea. So rehydration steps with the ORS in children with some dehydration. So proper demonstration and education on ORS administration is mandatory by health staff. Start initial 1 to 2 ml per kg every 5 minutes of a low osmolar ORS administered with spoon, syringe, paladi, and dropper. When the child accepts and drink, increase the amount 5 to 10 ml every 10 minutes and over next 2 to 4 hours administered about 50 to 100 ml per kg in case of some or mild to moderate dehydration. Never feed or push fast, but after 10 minutes if the child vomit out. Subsequent ongoing episode of diarrhea and vomiting will be replaced by about 60 to 100 ml of ORS in a child less than 10 kg and 100 to 20 to 240 ml of ORS about 10 kg child. Encourage the mother to continue breastfeeding during dehydration with oral rehydration solution. Encourage the mother to continue breastfeeding during rehydration with ORS and educate the mother to avoid carbonated beverage, commercial beverage, fruit juice, concentrate, coffee, and bottle feeding. It increases the diarrhea and worsen the condition. So with the different type of the ORS, there is a sodium bicarbonate based ORS, trisodium citrate based ORS, and reduced mortality ORS. Other variants are Resomal. There is a rehydration solution for malnutrition. There is a less sodium. There is a 45 milliequivalent per liter. And cereal rice-based ORS and super ORS. In Rosomal, it is specially used in case of malnourished children when there is a chances of circulatory overload due to its high sodium content. So sodium content is reduced in case of Resomal ORS. The children have a severe depletion of total body potassium, magnesium, and essential trace elements like zinc and copper needed for immunocompetence and important mitochondrial enzymatic function. Low sodium content of Resomal is very important as these children are more prone to develop cardiac failure with ORS containing higher sodium load. So Resomal should be advised to the malnourished children with diarrhea with dehydration. Mental apathy noted in these children is reported to recover earlier due to use of Resomal. Cereal or rice-based ORS, starch polymer containing complex carbohydrates such as rice, when slowly broken down into glucose, have shown to improve transport of sodium and water across the intestinal epithelium and were found to be effective without increasing stool output. Such cereal-derived carbohydrate polymer, it replaces glucose in a low osmolar ORS. It is called cereal-based ORS. Then what is super ORS? Super ORS incorporated with amino acid, there is L-alanine, glycine, and glutamine, fortified or oligopeptide, which enrich starch from rice powder and have been found to reduce stool volume, shorten the duration of diarrhea, and allow early introduction of feeding, mostly in case of cholera. So choice of therapy in case of cholera is a super ORS, but its main disadvantages are requirement of prior cooking, shorten half-life after preparation, there is 8 to 12 hours, and not effective in children with non-cholera diarrhea. Action of individual ingredient of ORS. What is the action of sodium chloride? Sodium chloride is a major extracellular element and it is a principal and essential element of blood which maintain osmotic tension of blood and the tissue. Potassium chloride is a major intracellular element and glucose, it facilitates sodium and water absorption through the intestine. And trisodium citrate, it corrects acidosis due to electrolyte loss. What is the role of zinc in diarrhea? So today's theme for this World ORS Day or a World ORS Week is Jodi number 1 is ORS with zinc. Zinc inhibit cyclic AMP induce chloride-dependent fluid secretion by emitting vasolateral potassium channel. Zinc also improve absorption of water and electrolytes. It improve regeneration of intestinal epithelium. It increase the level of brush border enzyme and it enhance immune response, allowing for the better clearance of pathogens. Role of probiotic in diarrhea. Probiotic are friendly bacteria that are similar to the organism that occur naturally in digestive tract. The potential mechanism include exclusion of pathogens by means of competing for binding sites and available substrate, and it lowering luminal pH and production of bacteriocin and promotion of production of mucus, that is lactobacillus, bifidus bacteria, and Saccharomyces boulardii. These are the probiotic used in case of diarrhea. So what is the advantage and disadvantage of different ORS solution? Sodium bicarbonate based ORS, it is less stable and stool output not reduced. But in case of trisodium citrate based ORS, there is a sodium chloride 3.5 gram, glucose 20 gram, potassium chloride 1.5 gram, and trisodium citrate, there is a 2.9 gram, and it is useful in case of acute diarrhea in children. So advantage, this trisodium citrate ORS, it is more stable and less stool output in high output diarrhea, and trisodium citrate, it increase intestinal absorption of sodium and water. Possible adverse effect of this ORS is hypertonicity in a net fluid absorption, and to overcome this problem, we should reduce osmolarity ORS. In conventional ORS, osmolarity is 321 milliosmol, but in low osmolarity ORS, the osmolarity is 245 milliosmol per liter. So there is a difference between standard conventional ORS and second hypoosmolar or a sodium reduced ORS. In case of conventional ORS, there is glucose is 111, while in case of low osmolar ORS, it is 75. In case of conventional ORS, the sodium is 90 millimole equivalent per liter, while in case of low osmolarity, it is 75. And osmolarity of conventional ORS, it is 331 instead of in low osmolar ORS, it is 245. So it is low sodium and low glucose in low osmolar ORS, important for a correction of dehydration in case of children. It decreases the severity of the diarrhea, also decrease the volume of the stool volume, and also decrease the duration at least 24 to 48 hours with the low osmolarity ORS. So low osmolarity ORS, there is a sodium already I told 75 millimole, that is 2.6 gram. Glucose is 13.5, and in millimole per liter it is 75, and osmolarity 245. In this content, one sachet of this content dissolved in 1 liter of water. Low osmolar ORS. It is launched in 2002 by WHO and UNICEF. So I already told low osmolarity ORS advantage, it lower the stool volume. Second, less vomiting due to this ORS, and fewer instances of unscheduled switch over to the parenteral fluid administration. Also, it shortened the duration of diarrhea 24 to 48 hours. No instance of hypernatremia, and overall increased efficacy over conventional ORS, and reduce stool bulk by favoring water movement from gut lumen into the body. So low osmolarity ORS is a safe and effective. So when this ORS is ineffective, when child having high purge rate or uncontrolled vomiting, severe dehydration, hypovolemic or septic shock, altered sensorium of the child with diarrhea due to dehydration, and severe electrolyte disturbance, in this condition, ORS therapy is not effective. Whom can be given to this ORS? ORS can be given to all age group with all etiology and in all country. How to administer ORS? Teach the mother, if the baby is less than 2 years, give 1 to 2 teaspoons every 2 to 3 minutes. In older children, give frequent sips of cup. An adult drink as much as they can and give estimated amount within 4 hours. In case of mild to moderate, that means some dehydration, give at least 50 ml to 75 ml per kg body weight of the child. So if the child vomit, wait for 10 minutes and then give ORS 1 teaspoon every 2 to 3 minutes. If the child vomit to drink more than the estimated, if child want to drink more than estimated amount, yes, there is a no harm, give more. How to prepare ORS? Dissolve the entire content of the packet in 1 liter of the drinking water, and it should be used within 24 hours. And doses and the requirement of the ORS in case of some or mild to moderate dehydration. If the child weight is known, amount of the ORS for rehydration during first 4 hours calculated, that is 75 ml per kg within 4 hours to correct dehydration. If ORS packet are not available, then use salt and sugar solution in 1 liter of water. There is 1 pinch of salt and 1 fist of sugar. There is a 5 gram of salt and 20 gram of sugar in 1 liter of glucose water. So rehydration in case of the malnourished children, we should advise Rezomal. The Rezomal, there is a sodium content is 45 instead of 75 in case of low osmolar ORS. Also, so it is osmolarity is also less. There is a 300 millimole per liter. So it is useful in case of malnourished children, because malnourished children, they are prone to cardiac failure due to high sodium content. So sodium content is less in case of Rezomal. So in case of malnourished children with cholera, we should advise Rezomal. So most common etiology in diarrhea in children, it is a viral diarrhea. There is a rotavirus diarrhea. So rotavirus, what is the characteristic feature of rotavirus diarrhea? Rotavirus diarrhea, there is an increased frequency and fluidity of the stool. There is a profuse watery diarrhea with severe dehydration, with electrolyte loss, and there is a electrolyte disturbance. Also, the less common is the bacterial diarrhea, also the parasitic and the fungal diarrhea. Most common diarrhea in children is the rotavirus, so the and with severe dehydration. While in case of adult, it is more of this bacterial diarrhea. So dehydration is mild to moderate. In case of children, it is severe dehydration. So when any child come to you with diarrhea in children, see the stool consistency. What is the frequency, consistency, what is the amount, presence of blood, mucus, and the duration. If there is a duration less than 1 week diarrhea, there is an acute diarrhea. If the duration of 2 weeks, it is a persistent diarrhea. And there is a 4-week duration diarrhea, it is a chronic diarrhea. And also it is associated with vomiting or not, also frequency, amount, and the presence of the bile. And also associated any symptoms, fever, there is a low grade, high grade, or moderate. So early signs of diarrhea, it is an excessive thirst. So whenever any child come to you with diarrhea, for the diagnosis, assess the child and in history to see the passing urine, how much frequency or how much urine output in 24 hours. And also see the general appearance, whether it is unwell, sick, very sick after the onset of diarrhea. Also see the activity. If there is a diarrhea, rotavirus diarrhea, it leads to the hyponatremic severe dehydration. The child is drowsy to semi-coma to coma. But if it is diarrhea, there's a bacterial diarrhea in children. It is mild to moderate or some dehydration. There is a hypernatremic dehydration. Child is irritable. So see the activity and what is see the mental status. Also the skin pinch. If you see the skin pinch of abdomen, if it is goes away immediately, there's a no adhesion. It slowly goes on. It is mild to moderate some dehydration, and it takes the skin pinch goes away. It takes more than 2 seconds. It is severe dehydration. So in case of diarrhea in children, you should assess both the one severity grade of dehydration and second electrolyte wise whether it is isonatremic, hyponatremic or hypernatremic dehydration. So who are the risk due to the diarrhea for mortality or high risk baby with diarrhea? When baby is neonate, there is a 20 less than 28 week or infant less than 1 year. When the low birth weight or the preterm or IUGR baby, they are a higher risk. Also severe acute malnutrition diarrhea, they are higher risk. Obese children, infant unable to breastfeed during illness, those with watery diarrhea more than 5, loose stool in cholera in 24 hours, and those with repeated vomiting, not accepting or retaining ORS, and those with altered sensorium or excessive tired or lethargic child. So these conditions, they are higher risk with children due to diarrhea. So rapid assessment of hydration and see the status and degree of dehydration. If there is a mild or some dehydration, there is no symptom, sensorium alert, eyes normal, mouth tongue normal, skin turgor normal, capillary refill normal, extremities warm, and pulse volume is normal. But in case of mild to moderate dehydration, there is symptoms, there is child is irritable, fatigue, restless, and there is a thirst, the early signs, and child eager to drink. And if you see the eye, there is a shrunken eyeball. Mouth and the tongue, they are dry, and skin turgor, on skin pinch, it disappears within 2 seconds, and capillary refill is prolonged less than 2 seconds, and extremities is cold in case of mild to moderate dehydration, and pulse volume is normal. But in case of mild to moderate, there is a breathing is normal, heart rate is normal, urine output is normal, and fluid deficit, there is a dehydration, it is less than 3%. But in case of severe dehydration, there is a mental status, it is apathetic lethargy, thirst is poor, inability to drink, deeply shrunken eyeball, tears are absent, mouth and the tongue, they are dry, skin turgor, the skin pinch, it takes more than 2 seconds, capillary refill is prolonged, and extremities are cold extremities, and there is subnormal temperature, and pulse volume, there is a weak, thready, and impalpable in case of severe dehydration due to diarrhea and also in cholera, fast thready pulse. Breathing also due to this hypokalemia, there's a metabolic acidosis and breathing is acidotic. There is a rapid breathing, heart rate is tachycardia, and there is a oliguria, decreased urine output in case of dehydration, and fluid deficit in case of severe dehydration is more than 10%. So in mild dehydration, fluid loss 5%, in moderate, it is 10%, and in severe dehydration, it is more than 15%. So to correct this dehydration in mild, moderate, and severe, there is a ORS guideline. If it is mild to moderate, you should give choice of therapy is IV fluid. There's a ringer lactate. If it is not available, then use normal saline. If it is mild dehydration, give 50 ml per kg. In the moderate dehydration, give 75 ml per kg. And severe dehydration, there is 100 ml per kg. If there is a severe dehydration, treat this ringer lactate 100 ml per kg. There is a first part, there is a 30 ml per kg. If it is less than 2 month or 6 month baby in 1 hour, and remaining 70 ml per kg in next, there is a 4 hours. While if it is more than 2 months to 1-year-old child with severe dehydration, give 30 ml in half an hour and remaining 70 ml per kg and 2.5 hours. That means if there is a diarrhea with lesser age group less than 2 months, you should treat this dehydration within 6 hours. While in case of higher age group child, more than 1 year baby with severe dehydration, give this 100 ml per kg in 3 hours. We are giving this, we take more duration to correct dehydration in lesser age group child to avoid circulatory overload. Next. So there is a, I already told, there is a 3 type of dehydration: isonatremic, hyponatremic, and hypernatremic. In hyponatremic dehydration, the serum sodium less than 130 milliequivalent, and hypernatremic dehydration, serum sodium more than 150 milliequivalent per liter. So in hyponatremic dehydration, in severe dehydration, child is drowsy to semi-coma to coma. But in case of hypernatremic dehydration, child is irritable. So today's this World ORS Day, my key message for this diarrheal disease in children, classified diarrhea based on timing and the content is clinically more useful for deciding on the management. 4 clinical types are common seen: acute watery diarrhea, it lasting several hours to day; acute bloody diarrhea; acute bacillary dysentery. Acute bacillary dysentery more common in children, and choice of therapy is antibiotic. And prolonged diarrhea more than 2 weeks is a persistent diarrhea, and 4-week diarrhea with malnutrition and undernutrition, it is a chronic diarrhea. Severe dehydration and sodium imbalance are common complications associated with diarrhea. Osmolarity disturbance needs to be considered with giving treatment for associated sodium bicarbonate condition. Children who are at high risk of complication due to diarrhea, less than 1 year baby, or underlying severe acute malnutrition, repeated vomiting, refusal to accept oral feed due to poor sensorium. So these baby, they are risk due to diarrhea for mortality. And the 2-pillar management of acute gastroenteritis, there is first by the oral reaeration and rapid reintroduction of regular feeding following initial fluid reaeration. And green banana diet has been found to hasten recovery from acute and prolonged diarrhea and may be useful adjunct therapy in resource limited setting in persistent to chronic diarrhea. Thank you.
Thank you, Doctor. Just one doubt, Doctor. Since you have covered all the aspects around ORS, like how much requirement maybe a baby requires and everything.
Right.
The only one thing that I wanted to ask is oral ORS good for fever, or maybe somewhere you have
also useful because fever, there is a it leads to dehydration due to this temperature. So it is also useful in case of any pyrexia, ORS useful. In case of vomiting, also useful. Also in diarrhea, bacterial diarrhea, viral diarrhea, also chronic diarrhea.
Mhm.
It is
And
useful.
maybe when we talk about ORS, there should be the basic ingredients. Maybe yes, water, clean water that is boiled,
Right, right.
disinfect, sodium and other thing. What are the maybe at home if we have to prepare ORS? What will be the basic requirements that we need to have?
Homemade, there is a salt and sugar and
Okay,
plain water, nothing else.
nothing else. They
Hmm.
have to
So
just heat.
one pinch of salt
Huh.
and one fist of sugar and 1 liter water. Homemade.
Homemade. Okay,
Hmm.
and
In
also.
case of this ORS, there's a
Hmm,
very sodium chloride.
hmm,
There is a 2.6 gram per liter. Second is a potassium chloride. There is a 2.5 gram.
hmm.
And there is a trisodium citrate, 2.9, 2.6 gram, 2.9 gram sodium per, and glucose, there is a 13.5 in low osmolar ORS. So osmolarity of these low osmolar ORS, it is about 245. It is useful in children because the sodium is less, because in to avoid this circulatory overload.
Okay, doctor. Doctor, most of the cases that we have seen, the usage of ORS will be either an acute diarrhea or similar to that. So, do we have any specific, requirement that this point of time only we need to give ORS to the kids?
So, so to assess the child if there is a dehydration or not, because one project is there, IMNCI integrated management of neonatal and childhood illness. Or roughly, the assessment of the dehydration, it is no dehydration, some dehydration, and severe dehydration. If there is a, if you see the child and there is urine output is decreased or shrunken eyeball, or there is if see the vital data is altered, and also uh, there is a mental status, it is drowsy or irritable, there's a dehydration is there. In case of mild, we should give this ORS, there is a 50 ml per kg in within 4 hours. If it is moderate dehydration, then we should give 75 ml per kg within 4 hours. If there is a severe dehydration, then there I will told there is a, it should be treated with intravenous fluid. There is a ringer lactate or normal saline. There is a 100 ml per kg body weight. If it is lesser age group child, less than 2 months, then we should correct this dehydration within 6 hours. While in case of higher age group child, more than 1 year, then we should correct the dehydration 100 ml per kg within 3 hours. So we are taking more time to correct dehydration in lesser age group child than the higher age group.
Okay, doctor. Doctor, one last question. Okay, you have mentioned we have different kinds of ORS, like from super ORS and homemade ORS, and from the rice also you have mentioned
Right, right.
one of the slide. So, wanted to know if you have to recommend to someone, which ORS you would be recommending to them.
So I already told there is a WHO initial available ORS, it is a conventional ORS. Due to high sodium content, it is not advisable in children. So WHO introduced this hypoosmolar ORS. There is a low sodium ORS to avoid this circulatory overload, and also it improvement is good with hypoosmolar ORS. It decrease the volume of stool, also decrease the severity, also decrease the duration 24 to 48 hours, and also there is a less chances of hypernatremia due to this ORS in case of hypoosmolar. So we should advise hypoosmolar ORS in children, but if children with malnourished child, we should advise Rezomal. There is a in Rezomal, sodium content is less, and to avoid this circuit overload in malnourished children. So in case of cholera, we should advise super ORS. Super ORS incorporated with L-alanine, glycine, and lysine, the amino acid based enriched ORS. So it is useful in case it is effective in case of cholera, and it decreases the severity, duration, and also the volume of the stool in case of cholera. So super ORS advised in cholera, hypoosmolar ORS in children, and rhesomal ORS advised in case of malnourished children.
Okay, doctor. One more question, doctor. This is regarding the one of the discussion that you have told about not to have aerated drinks or those kind of
Right,
things. So can
right.
you brief little more in detail so
Uh,
that
so
it will.
when we should not advise uh, these sweet drinks or the fruit juice, because it in this case there is a increased glucose content, and this increased glucose content, and it lead to it is called osmotic diarrhea, and it worsen the condition of diarrhea, and it lead to dehydration. So during diarrhea in children, we cannot advise, or we should not advise any cold drinks or any fruit juices or any beverages. It worsen the condition due to higher glucose content or higher sugar.
Okay, okay. So that will be applicable also for the adults as well, right?
Also.
Also for the adults. Okay, okay. Also, like how much water that maybe we can add? Maybe I think one ORS packet.
1 liter, 1 liter, one
1 liter.
sachet,
Uh-huh.
1 liter. Any plain water. No need to hot or boiled water.
Okay, doctor. I think I have asked all the questions that I wanted to hear altogether regarding ORS and like from the preparation of ORS, homemade ORS, and what are the basic, like how a simplified way you can make ORS at home and how it is helping lot of child kids to fight against dehydration, diarrhea, and whatnot. So, on behalf of MedPiper Technologies and Jonamed, we would like to thank Dr. Parmar sir, who have joined us today to give some insights on ORS applications and implementations for the child safety. Thank you, Doctor, for joining us today.
Thank you.